So Eric, what's going to come off the recommended guidelines? What would you take off that list of 4 or 5 different regimens?
Yeah, it's always, I think, a challenge for the guidelines panels because, do you really want to focus on the ones you actually use or the ones that are all reasonable options?
Right.
Right, and I think right now there's not a lot of people in a world of single tablet regimens using a regimen that requires 3 pills a day, even once a day like raltegravir.
Yeah.
So I think raltegravir has stayed on it because it's probably the cleanest drug we've ever used practically with regards to side effects and
Right.
drug-drug interactions, and clearly it's highly efficacious in every comparison, including against dolutegravir and boosted PIs. It's clearly a great regimen. I think it falls off on convenience, and at some point you just have to say, it's a perfectly reasonable option, but based on convenience, are there any reasons you would use it over the others?
Sure.
And that's becomes a discretionary point as to whether people want to leave it as a preferred option or not.
Right. Colleen, is there any reason to keep something that has a booster in it? Now that we have bictegravir?
I think that's a really good
FFPC?
point. It sounds like probably not. I think another thing to point out is I haven't seen the size of the Biktarvy pill, but some of the newer integrase inhibitors are incredibly small, and the TAF-based regimens
one's
are
very
small.
small.
And I figured it probably was. And patients really appreciate not having to take the big horse pills anymore. So, I often, do you want 1 big pill or 2 little ones?
And sometimes people pick 2 little ones.
They'll
sure.
pick the 2 little ones
Sure.
very often. So to have a small single tablet regimen is going to be, I think, very exciting.
Yeah, and I do think that, for example, elvitegravir cobicistat, I can't think of an advantage for that particular regimen of why you would pick it. But it takes time for people to change. They're early adopters and later adopters. I saw at the airport the other day, a guy used his watch to go through the
Security.
security, right, on his little Apple Watch, but there was someone right behind him with a piece of paper.
The big advantage of elvitegravir cobicistat was it was the single tablet regimen with tenofovir FTC.
Right.
And
now there's something else.
Yeah, now
Now
there's
we
something
have
else.
an alternative. And I do think your point about dolutegravir, we certainly have more clinical experience with dolutegravir than we have with bictegravir. And some people might be early adopters, other people might want to see a little bit more clinical data. That seems quite reasonable and that. And we do have to see the longer-term tolerability with bictegravir, but the studies look very good, as Eric pointed out.
And of course, there's those patients that say, if it ain't broke, don't fix it. I'm sticking with my regimen. And we have a lot of people on boosted elvitegravir right now. They'll be on it for a long time, I think.
I think that's a really important point. Yeah. Every time you talk to a community-based group and you talk about the current preferred options, everybody's hands go up, but I'm on atazanavir, ritonavir, or I'm on darunavir, ritonavir, should I change? It's like, absolutely not, right? You should only change if you want to.
Yeah.
But not just because the guidelines have evolved, because the guidelines have evolved in focusing on first-line therapy.
Sure.
Yeah.
Sure. But for maybe there are primary practitioners out there that share care with an expert. And so certainly when there's something new that comes along, it's probably willing to get a tune-up, whether that tune-up is by phone or by sending them off to the expert to see whether their regimen can be tuned. Because maybe some of those people on ritonavir have lipid abnormalities, and they could be tuned up a little bit.
So want to be on a single tablet regimen.
They want, right.
Yeah,
so I think that makes sense. But what we're talking about doesn't fit for everybody, Dan. So what about regimens that kind of fall outside for most patients?
I think there are fewer and fewer of those situations. But for example, Eric brought up the question before of the person when you have a concern about adherence. And there's been sort of a tradition. I'm not sure there's a lot of hard data around it, but there's been a tradition for considering the use of a boosted protease inhibitor as first-line therapy when you're not certain how reliably someone will take their medication because of the very high barrier to resistance. That generally means more pills, though, and maybe the potential benefits around risk of resistance are counterbalanced by the greater complexity of the regimen, and that's never actually been studied. But a lot of clinicians, people who treat a large number of HIV patients, still feel that a boosted PI is something they can rely on if there's somebody there about whose adherence they're particularly concerned. Another situation that could be an issue is if somebody really has advanced renal failure,
Sure, that's a tough
where creatinine clearance less than 30, where you really can't use even the newer versions, formulations of tenofovir, and if they also have a risk for cardiovascular disease, which almost everybody with advanced renal disease has,
right.
then you wouldn't want to use abacavir either, and so then you might be looking at a more unusual regimen. I actually think in those situations, clinicians who are not doing HIV care as their main
Primary job
should really refer to an expert, because it gets very tricky after that.